Thank you for joining us for today's webinar, Not All CKD is the Same, Why Cause Matters, presented by Responsive for CKD. My name is Bridget, and I'll be your moderator for today's session. And we're honored to have Dr. Brent Miller with us. Dr. Miller is a leading expert in nephrology and kidney diseases, and he'll be sharing his insights on why understanding the cause of CKD is so important for both patients and providers. Before we begin, just a quick reminder that we'll have a live Q&A at the end of the presentation, so please feel free to submit your questions anytime during using the Q&A feature at the bottom of your screen. And this session is being recorded, and a copy will be sent to the email address you registered with and will also be available in the Responsive for CKD newsfeed. So with all of that being said, let's go ahead and get started. Dr. Miller, the floor is yours.
Thank you, Bridget, please. So this is what I hope we'll cover, and I want to spend a little bit of time just on this slide so that if people zone out for the next couple slides, at least they leave with some understanding. So the first is, what is CKD? And I can't tell you how important that we need to define this better. So I'll tell you when I started training 30 years ago, there was generally not much attention paid to kidney issues for a variety of reasons. A lot of which is we didn't have good diagnostic or therapeutic techniques, and so often you would label somebody as having kidney failure or not having kidney failure, and that led to a lot of problems, as you can imagine, because kidney function and kidney problems are a huge spectrum. And so to just define it, whether you have kidney failure and you're on dialysis or have a transplant or you're not, was not leading to very good care, particularly upstream, prior to people having kidney failure. And so there was a lot of work done on this, and I'll give the National Kidney Foundation and at that time, what they called KDOKI, a lot of praise for this, is they were really the first group to really drive paying attention to what your kidney function was before you had kidney failure. And this is how we came up with the CKD staging process, which is great, and we'll talk a little bit about that. But what's happened is that a lot of the people involved in healthcare, such as Medicare, the insurance companies, et cetera, have then labeled this as a diagnosis. And so often people are now just defined by what their kidney function is. And that's just one aspect of it. And so what we want to do today is, I hope everyone will take away from this session, is that as a patient or a patient's family member or an advocate or a physician or a nurse, that we not only pay attention to what the patient's kidney function is and what stage CKD is, but what caused it, how they got there. And so to do that, we want to understand the causes of kidney disease, and we'll briefly discuss that. Although, as you can imagine, that is a multiple lecture discussion to go through those in detail. So we're just going to mention a couple of the big ones and just throw it out there that there are a lot of them. But as a patient, you should understand what yours is. And then we're going to talk about, well, yes, academically, that might be interesting. The physicians want to know what caused it, how it caused it, et cetera. But really, why does it matter to me? And in 2025, it's a big deal, where it may not have been a big deal in 2005. And the reason is that kidney problems are easier to diagnose. We understand these processes better. We understand what the prognosis of these are. And then really in the last 5 to 7 years, we're starting to get newer therapies that really address these problems that we didn't have. And so after sort of some stagnation in kidney treatments for 20 years, the last 5 to 7 years has shown dramatic introductions of new medicines, and there are many, many, many in the pipeline. So that's why. And then I want to leave it with, and I think I have 5 points, that when you see your physician, that really you shouldn't walk out of the room without understanding the answers to these 5 questions. And I'm not blaming anyone, but we really want to get these 5 questions answered if you're a patient with a kidney problem. And then we'll open up for questions. All right, next slide. So, the kidney world has changed. I think one of the frustrations as nephrologists is it seems like nobody knows it. and that's played out in many, many ways. And I'm laughing about it now, but it's not so funny most of the time. We seem to be under the radar in what's happened in the last 10, 15 years. There are better and newer diagnostic techniques. It's, as someone who's been doing this for 25 years, to me, it's amazing because there were kidney problems that we didn't understand. We knew something was wrong, and we couldn't understand what it was or what was causing it. And we now understand what it is, and we have diagnostic techniques. And then now we're developing therapeutic techniques. And so this is what, as a patient, you really want to understand your disease process much better, because this world is rapidly evolving. Next slide. So the other important point to make is the kidney has a lot of functions, and I just put 7 of the big ones. The kidney is just not an organ for making urine. That's obviously important. It's what, if you stop making urine, it's what gets you into trouble really quick. But the kidney does a lot of things. It removes the toxic waste products of your body's metabolism. The big one, of course, is urea. Urea is a water-soluble molecule of protein metabolism, and the kidney gets rid of it. The kidney controls salt and water balance. So that means, in some respect, every person who has high blood pressure has an issue with the kidney in one way or another. The kidney controls blood pressure. So if you have high blood pressure, you may not have kidney failure, but your kidney's not doing something right. The kidney controls acid-base balance. It controls electrolyte balance. It metabolizes and clears drugs. That's why a lot of our patients have to be, this is another thing when you leave a physician's office, even if you don't have kidney failure, maybe you have CKD stage 3 of any cause or 4, you're going to metabolize drugs a lot slower. And if your physician and your pharmacy isn't paying attention to this, you could get side effects from medicines that are the right medicine is prescribed, but the wrong dose, or perhaps the wrong medicine is prescribed. And then you get a side effect because your body can't metabolize it appropriately. The kidney controls anemia. And then the kidney actually is an endocrine organ. It has various hormonal functions, vitamin D, gluconeogenesis, those sorts of things are among the big ones. And then the reason we want to recognize this is, depending on which area of your kidney is injured, it affects these functions differently. Now, the more common injury, and the one that leads to our kidney failure, is the one that injures what's called the glomeruli, the blood vessels that in the kidney that filter the blood. But there are injuries, you can get injuries to other parts of the kidney and still have relatively normal clearance of toxins and salt and water balance, but you can have other problems. And probably some of the best ones that are known are some of the hereditary kidney stone diseases. Those people tend to have fairly normal kidney function, but they have a kidney disease that causes recurrent kidney stones, which is miserable. And that's because it impacts a different part of the kidney. It impacts the collecting system and the ureters. Next slide. So this is where, when we talk about chronic kidney disease and the progression to kidney failure, this is the part of the kidney where the damage occurs and is the cause of the problem. This is a glomerulus. We are born with approximately 1 million of these in each kidney. However, there is a wide variation of what people are born with. Normal at birth is between 500,000 to 2 million per kidney. So you can imagine that if you're one of the unfortunate people that's born with 500,000 per kidney, which is, quote, normal, but it's at the lower end of normal, as you get older, you might be more susceptible to having lower kidney function. If you were born premature, your kidneys probably didn't quite fully develop, and you would probably be born with less nephrons than somebody who is full term. So there's a lot of variation among how many of these we get. And then as we lose these, and this is where so diabetes attacks the blood vessels in the glomeruli. And then after diabetes attacks those, you start seeing leakage of protein and damage to these capillaries. And then you start to see scarring. So after 10, 15, 20, 30 years of diabetes, in not every diabetic, but in some diabetics, you get kidney failure. So on this picture on the right, you see the blood goes in at the top where that arrow is. Then it goes through these small blood vessels, which you see the little marks on them. They are filters. They are fenestrated. There are holes there. So your blood is filtered. And then the blood goes back through where you see the down arrow on the right, back to your body. Now, then you have the tubules, which starts there on the left side with the arrow going out, the proximal convoluted tubule. That's where the filtered blood goes. So now it's a filtration of plasma. And then your tubules in your kidney adjust that. And what's left after adjusting it and reabsorbing the nutrients and electrolytes is your urine. So that's what happens. But this is what we are generally talking about with CKD, is that these million glomeruli in each kidney are damaged. And so what happens when your kidney function starts getting worse is you are losing glomeruli. They are scarring and disappearing. They're turning into a scar. And unfortunately, this is one part of the body that generally can't heal. You can't make new glomeruli, and you can't regenerate that. Now, I will put an asterisk on that, is that if you catch a process in the kidney early and it's just undergoing inflammation and it hasn't progressed to a scar, if you treat that problem and halt the inflammation, the glomeruli can heal. That would be early IgA nephropathy, early lupus, believe it or not, even early diabetes. And so there's a caveat to that. But in general, once you damage these glomeruli, they cannot repair. I'll also mention that the process of aging, once we get to a certain age, and it's different for every person, somewhere between about 50 and 65, we just start having our glomeruli slowly scar at about 1% per year. We call that glomerular senescence. So that if we, with our current understanding of human physiology and treatments, if we all lived to 150, we would probably all develop severe CKD, just as a process of aging. That's another important point that I want to make here as we talk about the CKD staging, because I have, unfortunately, with us paying more attention to CKD staging, I'm seeing some older folks who really don't have many health issues. Maybe they have a little hypertension, a little high cholesterol. And because they're 85, their EGFR and their creatinine is slightly abnormal. And then somebody tells them, well, you have CKD. We'll talk about that in a minute. But what we really want to pay attention to is, do you have a disease process that damages these glomeruli that's going to result in markedly decreased kidney function and perhaps kidney failure? Next slide. So we don't want you leaving a nephrologist's office thinking that all you have is CKD. If you are leaving a nephrologist's office with just that, the next appointment needs to be a longer conversation. So we need to understand, well, what caused it? And there's not one cause, and that's probably the one take-home point of today is CKD is not one disease. CKD is a result of another disease process. The big one in the United States is diabetes. 40% of our CKD, and it's going up, probably going to be at 50% pretty soon, is diabetes. But then we have this whole host of other things, and this is not a comprehensive list. This is just to give you a flavor of all the different things that a nephrologist sees in our office. So we have autoimmune processes like membranous glomerulonephritis, IgA nephropathy, lupus nephritis. We have genetic causes. Probably the two most common and the two most well-known are polycystic kidney disease, hereditary nephritis, or what's been called Alport syndrome, named after Dr. Alport before they understood what caused it. There is something new in the last 15 years called complement-mediated kidney disease, which is relatively uncommon, but it's due to mutations in your complement system, but it's devastating, and we now have a treatment for it. Many other. There is an in-office test. There are several in-office tests that can now be done with a blood test or a cheek swab that can check for one of 397 genetic kidney diseases. So most of them are very rare, but they're out there. Cancer can cause kidney disease. Probably the most well-known is myeloma, when the myeloma proteins deposit in the kidney and start destroying the glomeruli. Pregnancy, I almost hate mentioning this, right? Pregnancy is a normal condition. Rarely do people get severe preeclampsia, which damages the kidney. You can have drug toxicities from drugs that are prescribed, from over-the-counter drugs, from other, from illicit drugs. And then you can have a plumbing problem. So the kidneys don't like pressure. So if your kidneys are blocked by anything, a kidney stone, a prostate, a mass, anything there, if the pressure is transmitted too high back to the kidney from the obstructed urine for too long a period of time, which is usually several weeks, the kidney will start to be damaged and scarred. So this gives you a flavor, but this is step one. We want to walk out of a nephrologist's office understanding, okay, I have CKD. What is the cause? Next slide. And then here are the 5 questions that I'd like you to have answered. What is the cause? And then, hopefully you don't get a blank stare back. But these are the sorts of things that should be at least possibly out there. What blood tests do I need to make the diagnosis? Do I need a kidney biopsy to make for sure? Do I need genetic testing? Do I need an ultrasound or a CT scan to make sure that the plumbing in my kidney is normal and that I have 2 kidneys and nothing's wrong there? Question 2, what is my current function? And that's very important because in general, kidney disease has no symptoms at the medium and mild stages. And then third, what's my prognosis? What's going to happen to me? How fast will my kidney function decline? Most people are seeing our nephrologist here in Indiana a little bit later than I'd like them to be seen. And so that question, unfortunately, is sometimes, how fast has my kidney function declined? And so we'd like to get upstream of that and have it, how will my kidney function decline? And then what is my treatment plan to either A, stop my kidney function decline, or, and this is important, slow my kidney function decline. There are a bunch of those diseases that I showed in the previous slide that aren't curable, but there are many that can be converted to just an annoyance. You can slow them down enough that they will cause minimal symptoms and you will not develop kidney failure and not need dialysis and not need transplant. And then lastly, once we go through all those 4s, there should be a plan B. Plan B is if all that doesn't work, what is my plan for when my kidneys fail? And in general, in the United States, we have utterly failed at this. We have very, very, very few people where we are successfully communicating preemptive transplantation. And then second, we are still in 2025, I think, at every major city in the United States. If I'm wrong, if somebody's from a city that they've corrected this, please let me know. The data from every major city that I know of, the majority of patients that require dialysis are not starting it electively as an outpatient. They are still reaching a crisis and starting in the hospital and often the emergency room. So I know no one likes to discuss number 5, and certainly it needs to be number 5. We want 1, 2, 3, and 4 to be discussed first, but we need to discuss number 5 before it is a crisis. Next slide. So now let's move on to CKD staging, GFR, and eGFR. So glomerular filtration rate just means the amount of blood that is going through those glomeruli, that picture that I showed you, per minute. So it's the amount of blood that, if you want to think of the kidneys cleaning, purifying, or filtering per minute. And then eGFR is an estimated GFR because it's really hard. We can do it, but it's really, really hard to accurately measure that blood flow in the kidney. Now, there's going to be a test that'll be available in the office in the next year or two that we might start using. But right now, it's basically a research test. And so we have to estimate it. So what we do is we take your blood test, which is creatinine. We put in a few variables like your age, your sex, and then we estimate that what the GFR is. And that's important that it's an eGFR because you're going to see it bounce up and down a little bit based on what you ate, drank, when the blood test was drawn, et cetera, on the day of the blood test. So people will say like, well, last month my eGFR was 44, now it's 41. What happened? Well, something potentially could have happened, but you don't want to get too excited at a few percent up or down. Likewise, I had somebody who say, well, gee, my GFR went up from 44 to 47. I must be doing well. It's like, well, we're good. You're stable, but let's not, it's an estimated GFR. There's an error margin. So let's not get excited about small changes up or down. As I talked about, newer and more accurate office measurements are coming. And then GFR is going to change minute to minute because the kidney gets 25% of the blood flow of the kidney. So if something changes in your body where the body needs to redirect blood flow elsewhere, it will clamp down on the blood flow to the kidneys and direct it to, let's say, the bowels or the brain. A kidney doesn't like that, and the kidney will decrease its GFR temporarily, and in severe situations in the hospital, maybe for a few days, but then ultimately the kidney recovers. So eGFR needs to be done when there's nothing else going on. You're not sick. You're not dehydrated. You haven't done anything really unusual. It's a steady state measurement when you're walking around and everything's fine. Next slide. So based on this, the National Kidney Foundation about 20 years ago came up with a staging system. And it was a brilliant idea because it really devoted a lot of attention to this. Because it started people thinking about where they were in the disease process. But you can also overplay it. Like I talked about, in an 80-year-old in the United States, a healthy 80-year-old, the average GFR is about 60. So we need to be careful about telling a healthy 80-year-old that they have stage 3 CKD. So you don't want to get ahead of yourself and start with this staging process. We want to go back to that original slide of what's my diagnosis, What's causing this? What's my prognosis? And what's my decline? 1% of people are born with one kidney. They don't even know it until something happens when they're older and they get an ultrasound. They say, gee, you only have one kidney. Those people's GFR is going to be slightly low because they only have one kidney instead of two. Do they have kidney disease? I don't know. Unfortunately, people have kidney cancers, and sometimes those cancers necessitate removing an entire kidney. So now those people have one kidney, which is completely healthy. Their GFR is going to be somewhere between about 45 and 60 in that kidney. Do they have CKD? I'm not so sure. Because their kidneys they're healthy. So their GFR should stay at 45 to 60. It'll go down a little bit as they age, as aging process, but I'm not so sure they have a disease. Next slide. And then this is kind of what I want to leave you with is, once, and I try to draw these for my patients the best I can. You have to be confident in yourself because you can be wrong. If I say you have IgA nephropathy and the average person with IgA nephropathy that has proteinuria and high blood pressure, they lose GFR at 5.2 milliliters per minute per year. That's an average. It might be wrong, but it's important to draw that out so that people can kind of understand what we're doing. And then the important part is, let's intervene. Let's change the slope of that curve to the green, blue, or red. And then the next point is, let's intervene earlier. Because if we can intervene at the green slope, that person will never require dialysis. If we intervene at the red slope, that's great, but we probably only delayed dialysis 4 to 5 years, which is great. Let's don't poo-poo that. That's 4 to 5 years you don't have to be on dialysis. But the difference between this is since the average age of people who have advanced or significant CKD is in their 50s, the difference between those two lines with the average US life expectancy is someone who will live their life without dialysis and someone who will live their life on dialysis and will have their life shortened 3 to 4-fold by having end-stage renal disease. This is a big deal. And in 2025, for many of our diseases, especially diabetes, the number one disease we have, we estimate that we can probably decrease the incidence of people needing dialysis by 30% or so, which is a big deal. Next slide. So in summary, we need to detect this. It's critical with some nuance. We do not want to be telling 85-year-old healthy grandmas that they have CKD when really all they are is a healthy 85-year-old grandma. But that's one side. That's one side of the issue. The other side of the issue is we are still telling people too late they have a kidney problem. We're saying, you look pretty good. You're going to work. You coach the basketball team of your kids. You're fine. It's like, we'll deal with this later. No, we need to deal with it now. We may not have to do much, but we at least need to have a plan. You need to get a diagnosis. Don't walk out of a nephrologist's office with your diagnosis being CKD stage whatever. That is a mistake. Understanding what your prognosis is once a diagnosis is made is going to help you plan what your life looks like and get a hold of it. There are treatments now for almost every kidney disease, multiple treatments, and they have pros and cons. That needs to be thought about and discussed and reevaluated and discussed again and reevaluated and discussed again. It's an ongoing thing. And then lastly, we need to discuss our transplant dialysis options when we know that the kidney disease is progressive, but before it's a crisis. And that's it. And with that, I'll be happy to take any questions.
Okay, it looks like we have two that came in here live that said, when your blood work is showing CKD issues in wrong direction, why is it not taken very seriously by your primary care physician? Oh, Dr. Miller, you're on mute.
I put myself on mute. I'm sorry.
No worries.
Um, no, no, that's exactly what we're saying. I mean, so I rounded on patients today, and so I had to come back to my office to do this talk. And so, I'm trying to eat better. I'm trying to be healthy myself, but it's like, you know what? I'm hungry. I'm going to miss lunch. So I stopped and got a sandwich. Um, it was vegetarian. So a little bit healthy, not much, but a little. But anyway, I was surprised, right? Because I went in and you had to enter your order on a screen. It's like do it yourself ordering, which I'm kind of old. I'm not used to. I'll kind of answer your question that way. To a certain, I think it's unfortunate in the healthcare environment we have now that you have to be your own advocate. I think you don't want to be your own physician or nurse. You don't want to treat yourself, but you have to become informed about what's going on. And it's again, I would want to know. It's like, you know, if you want to put in the chat box a little bit more color towards that, is it again? Don't get too excited about little 3 or 4% variations either way. But if they're ignoring the fact that your GFR keeps going down and maybe your proteinuria is going up and your blood pressure is not controlled, that's an issue. I think part of the issue too is we've dumped so much on primary care physicians now that they're overwhelmed. And so it may not be, it just may be they're overwhelmed. And so really that's something where a nephrologist needs to step in and say like, hey, your GFR is going down. What are we going to do about it?
We have a follow-up question that was sent in on the registration, actually, that asked if your EGFR can be improved.
So that is going to depend upon your disease. And that's another reason why we really need to get a good diagnosis from that. So, unfortunately, most of the disease processes that I see, the majority, diabetes, atherosclerosis, those would be my two big ones. And then you throw in a little hypertension with that. Then you add polycystic kidney disease. Those are diseases that usually are not going to improve. Those diseases, what we're going to try to do is slow them down, or stop. There are some diseases that the GFR can improve, and those tend to be your inflammatory diseases. Lupus, glomerulonephritis, IgA nephropathy, membranous glomerulopathy. All those diseases tend to improve. Some of the other ones too, like for example, myeloma. So if you have myeloma, which is a blood cancer that causes your kidney problem, if you treat the myeloma, the kidney function gets better. So the answer is yes, your EGFR can improve, but it depends upon what your diagnosis is.
We have someone asking here, what is the best treatment for lithium-induced nephrogenic diabetes? I apologize if I did I mispronounce that? I think I did.
Yeah, it's nephrogenic diabetes insipidus. Yeah.
Okay, there we go.
Yeah.
She has
That
stage
one's a
4.
tough one. Yeah, that one kind of becomes a tough one. Probably, ask your nephrologist about that. Some people have tried like amiloride and some other things, but so just so people know what happens in that case is the lithium damages the the tubules in the kidney that reabsorb water. So what happens is that you basically waste water. That's why it's called diabetes insipidus. Remember, diabetes was where it came from is before they understood what caused it is, your sugar would be super high. You'd put a bunch of sugar in your urine. That urine acts as a diuretic and causes you to go to the bathroom immensely. And this is before there was insulin or anything else. So these people had blood sugars of like 1,000. And so they were going to the bathroom all the time, getting dehydrated. That was diabetes. But there was a second type of diabetes they called diabetes insipidus, which wasn't from sugar. It was another problem, and that's a problem actually at the kidney, where the kidney just can't reabsorb all the water. So your sodium goes a little bit higher, and you do that. That one's a tricky one because it's chronic. I mean, it's. I would tell you probably discuss that with your nephrologist, because that one can be tricky to deal with.
Okay, we have someone here asking, I have one kidney due to CCRC in February 2024. This discussion has been extremely enlightening. My oncologist ordered an iron infusion as my blood work is showing close to anemia. Is this unusual?
What's your GFR?
If you'd like to throw that back in the chat. I'm looking here. From that, oh, GFR is 54.
So that's a little. So yes. So remember, the kidney makes 90% of your body's erythropoietin. And then also, when we don't completely understand kidney failure. We don't understand what all of the molecules that the kidney gets rid of when they build up do. But it's fairly clear that one of the things that some of the molecules that build up do is they slow the bone marrow down. So that when you have kidney problems, your bone marrow does not make red blood cells as fast as it used to. So it's very common to start getting anemia in most kidney diseases. Polycystic kidney disease is one that it doesn't for a strange reason. But it's very common as your GFR gets into the 40s and 30s that you start having a mild anemia. But what we try to do, and then in that case, if it gets really bad, that's when, with the hemoglobin lower than 10, that's when we start thinking about giving people erythropoietin injections, which is the hormone the kidney makes. But prior to that, what we like to make sure is that people have all the building blocks to make red blood cells. And it is very common for a lot of different reasons. In people that have I'm going to call it medium CKD, which, you're kind of there, 54, that's pretty good. That they are what's called functionally iron deficient. So what we like to do is get their iron up to a level that's not becoming a limiting factor to making red blood cells. So what you're describing is a very common first step in people who have an anemia with CKD. And I'm going to guess with the GFR 54, it's going to work. I don't know anything else about you, but I'm just playing the odds. That's probably going to work. You're probably not going to get into significant problems with anemia until that GFR gets down into the 30s. And that's just, that's not medical advice. That's just, the law of averages.
It looks like we have a couple questions about water in here. There's asking, does drinking more water help in decreasing progression? And what are your thoughts on hydrogen water in the improvement of
Yeah, I really don't. Yeah, I don't have any thoughts, positive or negative, about the hydrogen water. I don't have strong feelings either way. If you ask me personally, I don't think it's a benefit to kidneys. Is it going to harm? I don't think so either. If you like drinking hydrogen water, it's like, okay. But so I'm going to give you a nephrologist answer to your question. No one likes my answer to this. So it's like, just, everyone's going to be like, oh, it's a terrible answer. That a nephrologist would like people to make about 2 liters of urine a day. That's what we would like. And you really, unless you have kidney stones, you really don't need more than that. If you have kidney stones, we'd like you to push it to probably 3. But if you don't have kidney stones, drink and eat enough that you make about 2 liters of urine a day. Now, depending on what you do, that's going to be a different amount of water you drink every day. If you're out working in, it's nice here right now in Indiana, but 2 weeks ago it was 100 degrees. And if you were working in your garden, you probably needed to drink 4 liters of water that day. But Today, it's nice. It's like 70 degrees and not humid. So you don't have to drink that much. There's no advantage to drinking extra water with kidney disease. You just don't want to be dehydrated. So do whatever you can to not be dehydrated. Doing extra is not going to help. And I think most people in the United States probably don't drink enough. I think too many people live on the edge of dehydration, or at least underhydration, if we will. But going extra is not going to help.
What are the chances of getting a transplant, and what are some ways that I can know if that's right for me?
Well, I mean, I think one is talk talk to your physician, and then there are a huge number of resources on this, including Responsum, and there are a huge number of people that have gone through this process that would be more than happy to walk you through that. In general, transplant is the preferred treatment for kidney failure. And I say preferred. And remember, it's a treatment, it's not a cure. And so you're trading the symptoms of kidney failure and potentially dialysis, which is great for a functioning kidney, which will give you a GFR between 45 and 60. But on the other hand, you have to go through a surgery, and then you have to take lifelong immune suppression to prevent your kidney from rejecting. That is still a preferred treatment because in most people, it's going to, one, the quality of life is better, and two, your life expectancy goes up by 2 to 4-fold. So now you don't need a kidney transplant until your GFR is below 20. So, but again, this is the kind of thing that if your kidney disease is progressing, and that's where this starts. If your kidney disease has been stable for 20 years, you probably don't need a kidney transplant. So we need to know, do you have a progressive kidney disease? Where is it at? And then that discussion is, when the time comes, should I think about a transplant?
So we have this question here. How is CKD different for someone with a history of leukemia, bone marrow transplant, and chemo compared to someone with a genetic CKD diagnosis?
Well, we're assuming that you also don't have a genetic. Even if you've had that, you could still have a genetic cause. I mean, it should have already been picked up in most cases. But so nephrology is at right now where oncology was about 30 years ago. So with most of these oncology treatments now, they're amazing, but some of them have detrimental side effects to the kidney. And then also, unfortunately, some of the side effects of going through a cancer and treatment, such as like a severe infection or something like that, can also sometimes damage the kidney a little bit. In general, the processes that cause CKD after cancer treatment or bone marrow transplant are usually not diseases that directly attack the glomerulus. What they do is they just cause a little bit of scarring and fibrosis. So generally, once you remove the insult, once the cancer is gone, or once you're done with the chemotherapy, you may have scarred a significant part of your kidney, but hopefully it's not going to be progressive and progressed in stage renal disease. But you're exactly right. It's a completely different disease. And discussing that, discussing your specific situation with the nephrologist is the way to go. And anything anyone says about PKD or IgA nephropathy or Alport syndrome or anything else, you can kind of cover your ears.
What if you have several possible causes, like type 2 diabetes and uterine radiation damage?
Yes, and unfortunately, we're not in humans. We just don't do one thing in our lives. So those things can sometimes be additive. However, one of the things that I think is really, really important only 30% of people with diabetes get diabetic nephropathy. Only 30% of people get diabetes in their kidney that have diabetes. You're just because you have diabetes does not mean you're destined to get diabetes in your kidney. And so one of the things you'll want to talk about with your doctor is make sure if they're telling you that, hey, diabetes is causing your kidney. Well, is it? Because it's fairly simple to figure. You don't even have to do a biopsy really to figure it out. The hallmark of diabetes in the kidney is leaking a lot of protein in your urine. So those are the kind of questions you'd want to ask. How much, how bad is my diabetes in my kidney? Because not every diabetic, even not every diabetic with kidney disease has diabetes as the cause of their kidney disease.
Someone here asks, what stage should we be referred to a nephrologist? My doctor just told me to drink more water. I'm 57, found better, had CKD stage 3A by accident. Is this normal?
So, yeah, I mean, 50, right? A GFR of 57 for a 54-year-old, if I got those numbers right.
It says they're aged 57. I don't believe they say, but they said they have stage 3A.
So it'd be a GFR between 45 and 60.
Okay.
So that's significantly below normal. And so you may not have anything that's serious or progressive. You may have been born this way, but you're young enough. Your life expectancy is 30 years in the United States. So I think that's worth a one-time trip to a nephrologist to say, hey, if the primary care doc, doesn't answer those 5 questions, then it's worth a one-time trip to a nephrologist to get those 5 questions answered.
What would, just out of curiosity, be your the same suggestion just in general? Uh, when should someone advocate for themselves that they need to go speak to a nephrologist because they might not be getting the full picture from their primary care because they may be overwhelmed? Is there a time when it's too soon to seek specialized care or?
Yeah, I mean, that's when I get, that's when we as nephrologists get a little bit worried when we're out there saying 1 out of 9 people has kidney disease. It's like, we don't need to scare grandma that she's going to be on dialysis
Yeah.
because she's an 85-year-old who has a GFR of 58. So in general, if you think you have a kidney disease,
Mhm.
it's probably a good idea to get it evaluated at least once by a nephrologist. Now, the other thing is and this gets a little bit probably in more detail than people want to hear on this talk. Well, what are some of those markers? Well, if you have protein in your urine, that means your kidney, those filtering units are damaged. So I would say that if you have protein in your urine and your GFR is low, doesn't matter what it is, you need to be seen. Something is wrong. It may not be serious.
Mhm.
It may be, it may not be, but it's probably treatable. So that should be the case. If your GFR is decreasing, so then the person who said their GFR is 54 at age 57, well, if 20 years ago, if your eGFR was 54 or 58 or 60, it's like, okay, you weren't born right, but it hasn't progressed in 20 years, so we can probably just keep watching it. So you want to get those pieces of data, and if those pieces of data are not reassuring, then you should be seen sooner than later. If your kidney function is declining, or if there is evidence of damage ongoing in your kidney, which on a urinalysis would show protein in your urine or blood in your urine, that's an indication there's inflammation and a problem. So those 2 situations probably need to be seen now. If it's just, hey, my eGFR is a little bit low, it's been low for 30 years, it hasn't changed much, my urine's normal, my blood pressure is controlled, I feel great, you can use your own judgment. But what we don't want to have happen is 10 years down the road, have you show up with not feeling well, you're fatigued, your blood pressure's high, you come in and they tell you your GFR is 10.
Yeah. Trying to catch it on that green line on your graph
Yes.
earlier. Yes. Okay, so let's see a couple more here. What someone's asking what an ideal blood pressure reading is with one kidney at 73 years old.
That's a tough one. Because so it's interesting that, the new blood pressure guidelines were just released about a week ago, and they're actually, they're very, very good. They're much better than the blood pressure guidelines of the last 20 years or so, because basically what they say is blood pressure should be individualized for the patient. And so and then obviously, we want to be careful as people get older about too aggressive blood pressure control, because your arteries tend to be a little bit hard, and so low blood pressure can be a problem. And so, if you want to ask me that, generically that question, not knowing, again, not medical advice because I really don't know anything else about you, the textbook answer would be, a systolic blood pressure of between probably 120 and 130. And remember, it's a resting blood pressure. It's not the blood pressure that you get when you run up the stairs, when you just were in traffic for an hour yelling at people, when it's a resting blood pressure, both feet on the floor, resting blood pressure.
Sorry, I'm just going through a couple of the ones that were submitted during registration. I've been treated by a nephrologist for 4 years. I'm not sure of the cause. Should I insist on biopsy?
Okay, so we do about 150 biopsies a year in my practice. I'm not volunteering for one if I don't need one.
Yeah.
So,
There.
but I think I wouldn't, again, don't be your own physician. Don't, because at some point in time, my grandfather used to have a saying, if you go into a barber shop, you'll get a haircut. So it's if you ask for something in today's environment, somebody will do it. So we only want a kidney biopsy if it's going to help. So I think what you want to go in there and say, like, if you don't have a diagnosis for why your kidney functions lower, it's like, well, what happened? I mean, what caused it? I would say we don't do kidney biopsies in the majority of our patients. Usually with a careful history, blood tests, and examination of the urine, we can give the diagnosis in probably 90% of people, and we don't need a biopsy. So, but what you do need is a diagnosis. So I would ask, what is the cause of my CKD?
Has there ever been a situation where you get a cause that's undetermined? Or is or should everyone leave your office with a diagnosis and cause?
Yeah, I mean, again, it's the kidney gets 25% of your blood flow. So the kidney is exposed to a lot. And so, like someone else asked at the question a while ago, it's like, well, I have multiple causes. Yes. And that is sometimes that is the answer. It's like we can't pin it down on one cause.
Mhm.
And so, and sometimes I think you just need to ask your doctor to step out of the comfort zone a little bit and say, like, okay, I understand you can't give me, I don't have polycystic kidney disease. I don't have a mutation, in polycystin 1 or polycystin 2. I get it. I don't have a clear cut absolute cause of this, but can you give me your best guess as to what caused this, what my prognosis is, and what we're going to do about it? And there are many people that I tell them, it's like, listen, I don't know what exactly happened here, but you've clearly lost this kidney function from here to here over the last 10 years. It looks like this is happening. Here's what I think happened. So sometimes it's a little bit like CSI, and that's okay. If your doc's best guess is like, I'm not exactly sure, but it looked like this happened. That's okay. More importantly, what are we going to do about it?
That's great advice. I've seen that come up a lot. Just over the years, that response time for CKD has been live. And I think so many of the questions come with like there's this hesitancy for self-advocacy, in the doctor's office. You get a little nervous, and especially like if you're advocating and you're just getting those vague answers, that's helpful talking
You
points
have
for
to
the
get, I mean, I'll
patient
give
to
you an
bring.
example from a patient I saw yesterday. So I'm the third nephrologist this patient has seen because her one nephrologist retired and their other one is moving out of town. So it's like I end up, I'm the third person this person's seen, and they just call her CKD, and she's frustrated at it because she's a fairly engaged patient, and it's like, hey, I'm right there with you. It's like, okay, let's try to figure this out. Well, and of course, she's been seen in different hospital systems, so none of her records aren't all together. You have to get them from 3 different
Uh,
systems, so it's not easy. But we
yeah.
sat down and we got this, and we found out that her kidney function, which had been stable since 2016, but it dropped off dramatically from 2015 to 2016. So it's like, okay, what happened, Mrs. So and so, in 2016? She said, well, that's when I had my hepatitis C. And so it's like, oh, so then we get the records from there, and we see that she had proteinuria and hematuria with her acute hepatitis C. They treated her hepatitis C. The hepatitis C goes away. The protein in the blood goes away. The blood in the urine goes away, and she's been stable since. She had kidney disease from hepatitis C. And so I mean, she and I actually is it often doesn't work out that nice,
Right.
but it's like we're both both she and I are very happy at this visit. She's
Yeah.
walking out saying like, I'm not gonna, everyone else is telling me I'm gonna be on dialysis in 10 years. I'm like, no, you're not. You're cured. I mean, essentially, don't
Yeah.
go start smoking and everything else, but you're cured. Yes, your kidney function is not normal, but we've treated the cause. You haven't declined in 8 years or whatever. You're going to be fine. So I think that's the kind of conversation I don't want to put my colleagues, my nephrology colleagues, under so much pressure to be able to give everyone a perfect answer, because you can't. But we should at least be trying.
Would it be helpful to bring your own records when seeing new physicians if they're not, or is that,
Yes, yes.
yeah.
It's somebody asked the question. My primary care doctor is kind of blowing off my GFR decline.
Yeah.
Draw a graph. Go into your portal, get your labs, put it on. We're doctors. We're very good at looking at graphs. Put your EGFR on a graph and show them the downward trend and say like, hey, we got to stop this.
That's good advice. It looks like we're coming to the top of the hour here. So I just wanted to thank you again, Dr. Miller, for your presentation and answering so many of these questions. We've gotten such kind feedback already in the chat here of how helpful this session is. And great news, it's been recorded, so you'll be able to go back and view it all again. We'll be sending it to the email address that you registered with, and it will also be featured in the Responsum for CKD newsfeed. So thank you again, Dr. Miller. We're so grateful to have had you and look forward to watching this presentation again in our newsfeed.
All right, very good. Thank you.
Have a good one.